Hi, everyone. Welcome to the second week of remote learning. We're going to cover psychological disorders this week, chapter 14. So your first assignment is to read the chapter to gain some familiarity with the the various psychological disorders, and then listen to this PowerPoint presentation. So psychological disorders are of interest to a lot of people because many people wonder about themselves, that they feel, think, and act sometimes in an unusual way, and they wonder if their behavior is abnormal. Also, people want some explanation for the behaviors of other people that appear irrational or difficult to understand. And so we'll go on to slide 3 from here. William James, who you met in chapter 1, said to study the abnormal is the best way of understanding the normal. Now, there are more than 450 million people suffering from psychological disorders, as reported by the World Health Organization in 2004. So this is an old statistic, and this does not consider the great drug epidemic that we've experienced over the past decade. So there are more than 450 million people suffering. Now, researchers have looked across cultures to examine disorders. And what they have found is that some disorders are specific to one or just a few cultures only. Excuse me, and this is what we call culture-bound syndromes. Now, depression and schizophrenia exist in all cultures around the world. There's a phenomenon called medical school syndrome, also known as medical student syndrome, and it's relevant to the study of psychological disorders. It's known that many medical students, while they're in medical school, begin to think that they're suffering from the various physical and psychological disorders that they're studying. So I want you to be aware of this. Okay, you may recognize certain symptoms, but you may not be experiencing the full syndrome. Now, some people in studying psychological disorders, do find out that they have a disorder. But if you have one or two symptoms, it's probably quite human and normal, and you don't have the disorder itself. So I just want to forewarn you. I had students the first year I taught here at Thomas More coming to my office at the end of the semester quite distraught, saying that they thought they were suffering from all of the disorders we had studied. So be careful if you're concerned, if you get anxious, email me or call me and let me know so we can have a discussion. So in this chapter, we'll be looking at diagnostic categories or diagnostic labels from the DSM, the Diagnostic and Statistical Manual of Mental Disorders. So labels can be helpful to professionals, but they also can be destructive to people suffering from disorders. So diagnostic labels can help us predict the future course of the disorder. It can suggest what type of treatment is appropriate, and these labels guide research. But labels can color our perceptions. So you see on the slide two names, Rosenhan and Page, and I'm going to begin with Rosenhan. He did a study in 1973 exploring the biasing powers of labels. So he and 7 of his colleagues went to various emergency rooms reporting symptoms of hearing voices. And they said that the voices were saying things like empty, thud, hollow, existential type words and ideas, which is not found in the literature. So this should have raised some red flags in the people doing the intake. All 8 of the people in his study were diagnosed as psychotic and they were hospitalized. So back in the 1970s, doctors could hospitalize people even when they weren't suicidal or homicidal. Today, you must be suicidal or homicidal in order to be involuntarily hospitalized. Excuse me. Once admitted then on the ward, these patients no longer reported symptoms, and many of the inpatients on the units knew that these people were imposters, but the staff did not. Okay, the average stay for these 8 different individuals was 19 days. One person was held up to 57 days. Mental health professionals found causes for their disorders. For example, a reaction to mixed emotions about parents. One mental health professional in her notes wrote that she saw the patient taking notes and this indicated paranoia, when in fact this particular individual was taking notes to make observations about the workings of the unit in order to keep from being bored. And so what these mental health professionals were doing was seeing the individual through the lens of their diagnostic label. And thus, the label was quite biasing. So we need to be very cautious in using labels. A woman named Page in 1977 had a female colleague call 180 people who were advertising apartments for rent. And when she asked if the apartment was still available, she usually got a yes. Now, another colleague called the same the same apartments, and when at the end of her description of herself, she said she was recently released from a psychiatric unit, 3/4 of the rental properties said that they had no vacancies. So again, labeling can be quite destructive. So even though people in our society are becoming more knowledgeable about psychological disorders, many people remain unknowledgeable about disorders. So labels can stigmatize the person. Another person did a study named Ellen Langer, you don't need to remember her name, and she had subjects who she put into 2 groups. And each of the subjects saw an interview in a video format. And the first group was told nothing about the video, about the interview. And they saw the person as normal when they were questioned after viewing the interview video. Group 2 was told that the interviewee was a psychiatric patient. Those people saw the person as disordered, some as paranoid, some said passive-aggressive, or some other psychological issue. So labels influence our thinking. Oftentimes we see what we expect to see. So again, be cautious in labeling. Don't diagnose yourself, don't diagnose your friends or your family. People have been interested in odd and unusual behaviors going back to ancient times. So psychological historians have looked at how people have viewed abnormal behavior throughout history. And they've come up with 3 basic themes: the mystical, the scientific, and the humanitarian. Now, these themes do not follow a straight timeline, so I'll talk about each of these on the following slides. Going back to ancient times, the first proposed cause of psychological dysfunction was spirit possession. And so if someone was possessed by spirits, people looked for ways to get the spirits to leave the individual suffering. And so you see three types of treatment: trephining, exorcism, and various types of torture. Here you see a skull that was exhumed by archaeologists with 2 holes drilled into the skull. Archaeologists and historians see evidence of healing around these holes. And so what they understand about this process was that ancient people would drill holes into the skull to let the spirits possessing the suffering person to leave the body. And so probably this did not kill a lot of individuals, as they see evidence of healing around these holes that were drilled. Now you see other types of treatment that I mentioned on the previous slide. Exorcism was another, and all types of torture. And the purpose of the torture wasn't to punish the individual suffering, but they intended to make the body unpleasant so that the spirit would leave. But obviously it was very painful and, quite unpleasant for the individual experiencing these types of treatment. From a scientific model, we see that the cause proposed was biological or biochemical. And a scientific explanation of psychological dysfunction was proposed by Hippocrates back in the 300s BCE. As you know, Hippocrates was the father of modern medicine, and he also was interested in psychological disorders. And he proposed the humoral theory of psychological disorders. He believed that people had 4 bodily fluids, and when these 4 fluids were imbalanced, there would be some type of psychological symptom or disorder. So you see on the slide, you don't need to remember these 4 fluids, but he talked about black bile. If it was in balance, we might become depressed, or what they called at the time, melancholic. Yellow bile, okay, if it were imbalanced, we might be choleric. And what they meant was that the person might be overly aggressive and overly angry. And then phlegm. Okay, an imbalance of phlegm led to a phlegmatic individual, and this might be a person who's apathetic and just too calm for their own good. Okay, blood. An imbalance of blood would lead to a person being sanguine, and so the person might be very courageous, hopeful, playful, carefree, but we could also see the opposite end of the continuum with those various characteristics. So any of you who've read Chaucer's Canterbury Tales might be familiar with the humoral theory. And when physicians discovered that syphilis led to mental disorders, they started using medical models again to review the physical causes of these disorders. So to tell you a bit about syphilis, those suffering advanced syphilis oftentimes had psychotic symptoms. They would hallucinate, they would have delusions, they might act in very disorganized ways. And so the people with syphilis who contracted malaria, if they survived the malaria, no longer suffered from psychosis. And so what doctors did, they began to inject those people suffering from advanced syphilis with the blood from malaria patients. So as you can imagine, some of them died, but some of them were cured. So this was really the first time psychological symptoms connected with a curable disease. And so you see some terms on the slide that are medical in nature. And so we use some of these as we talk about psychological disorders. The first is etiology. I want you to know that word. It's the cause and the development of the disorder, etiology. The second is diagnosis. So this is an identification of symptoms in distinguishing one disorder from another. And so an easy abbreviation is DX. The third is treatment. So this is how we treat a disorder in a psychiatric hospital, in a clinic, in a private practice. So TX is the abbreviation. Prognosis is the forecast about the disorder. What is the course of the disorder and what do we expect the outcome to be? The third tradition is the humanitarian tradition or model. This model suggests that dysfunctional behavior is due in large part to poor treatment. So back in the 1400s through the 17 and 1800s, people who were exceptionally disordered oftentimes lived in places called asylums. These asylums oftentimes chained people. People were exposed to extremes of heat and cold. They didn't get proper nutrition, and oftentimes they would live in their own excrement. St. Mary's of Bethlehem, as you see on the slide, in the 1400s was one of these asylums. And people in the community, this was right outside of London, oftentimes on weekends would pack picnic lunches with their families and sit outside the windows of the asylum to watch, in quotes, the crazy people. So this was a source of entertainment. People really did not understand psychological disorders, did not view people suffering from them as humans deserving of respect and good treatment. Now, in the late 1700s, we find a man named Pinel at the hospital in Paris named La Bicêtre. He released patients from their chains. I believe there's a famous painting in your textbook showing this incident. This was famous. His unchaining of people spread around Europe and eventually to the United States. And so this increased the morale. Not only did he release people from chains, but he began to have staff treat these people humanely and provide much better living conditions. So they would have fresh air, activities, decent food, etc. And so Pinel started a worldwide movement now called the Humanitarian Movement. The Quakers, William Tuke being the leader of the moral treatment of people suffering from psychological disorders, was part of this humanitarian movement. So we think of this as the humanitarian model or moral treatment. So the Tuke retreat was in England, and it was a beautiful place with a lot of land. The patients would help farm and garden. They had lots of room to move about, good, respectful treatment, good nutrition, good living conditions. In the United States, we see the names Dorothea Dix and Benjamin Rush. They were proponents and advocates of humanitarian treatment of people with psychological problems. One of the big challenges in the clinical field is determining what is dysfunctional. Or another word for dysfunctional is maladaptive. Where's the line between normality and abnormality? There's a nice quote from your textbook from Herman Melville's Billy Budd. It says, who in the rainbow can draw the line where the violet tint ends and the orange tint begins? Distinctly, we see the difference of the colors, but where exactly does the one first blindingly enter into the other? So with sanity and insanity. Now, if someone withdraws and stays in their room for 3 months, is this dysfunctional? If a man loses his son and then loses interest in his former activities and isolates for a few months, is this normal grief or is it dysfunctional? So where is the line between zany creativity and bizarre irrationality? There was a picture in a former textbook of a man who shaved his head and then put different colored push pins into his scalp, okay, and walked around gaining a lot of attention from, the odd and kind of bizarre portrait of himself. Abnormal or not? So it is often challenging to define abnormality. So in an attempt to define abnormality, mental health professionals look at the following 4 criteria. The first is significant distress. Okay, now, in and of itself, significant distress doesn't always define abnormality. In some psychological disorders, there's no distress. So, for example, someone experiencing bipolar disorder or what used to be called manic depression, when they're in a manic state, they're high, they're exuberant, they're on top of the world, and they don't feel distress. In the early stages of substance disorders, people are feeling good. Okay, they use a drug or use alcohol in order to decrease distress, and they actually don't feel distressed, at least in the early stages. So distress in and of itself doesn't always define psychological dysfunction. The second criteria we use is significant impairment. So this is impairment in social, occupational, and other important areas of functioning. But again, there's some problem in using significant impairment alone. In some disorders, there's no impairment. Some people experiencing anxiety disorders or experiencing depression may not be impaired in their everyday functioning. The third criteria is risk to self or risk to others. So suicidality and homicidality. Now, some people who are suicidal do not have a psychological disorder. Same is true for people who are homicidal. The fourth criteria is culturally unacceptable behavior. But many people engage in culturally unacceptable behavior, like the guy who has his head full of multicolored push pins. We can look at Lady Gaga's meat dress, among many other culturally unacceptable behaviors. And those behaviors are not necessarily indicative of a psychological dysfunction. The DSM-5, the current edition of the Diagnostic and Statistical Manual of Mental Disorders, used by mental health professionals to diagnose psychological disorders, says that there must be one of 2 things in order for a person to be diagnosed with any psychological disorder. The first is significant distress and or significant impairment in functioning. So a person has to have one or the other, distress or impairment, in order to warrant a diagnosis. Today, when we look at the causes of abnormality or psychological dysfunction, the etiology of dysfunction, we look at three contributing factors: biological, psychological, and sociocultural factors. So we're back to the biopsychosocial approach, which you were introduced to in Chapter 1. The biopsychosocial model assumes that biological, sociocultural, and psychological factors can all influence and combine and interact to produce a disorder. And so two people could have depression, but the depression could be due to different influences in each of those people. So you can look at the chart on your own. There's more information in your textbook about these various contributing factors. Just want to say a bit about sociocultural influences. What we know is that the incidence of psychological disorders is doubly high among those living below the poverty line. So the greater the poverty, the greater the incidence of psychological disorders. So this correlation raises some questions. So does poverty cause psychological disorders, or do psychological disorders result in poverty? The answer depends on which psychological disorders you're looking at. So schizophrenia often leads to poverty, yet the stresses and demoralization of poverty can lead to psychological disorders like depression in women and substance disorders in men. So today we have two models explaining the etiology of psychological disorders, the biopsychosocial model and the diathesis stress model, which I'll talk about in the next slide. The diathesis stress model. A diathesis is a genetic predisposition. So the diathesis stress model says that people have a genetic predisposition and they develop symptoms when they're under stress. So the stress triggers the activation of the genes. The genes are expressed when a person is under extreme levels of stress. So this has often been true in my clinical practice. When people come in with symptoms, I ask what's going on in their life, and almost always it's an intense period of stress. And so the stress can activate the genetic predisposition toward a psychological disorder. Psychology and psychiatry uses a classification system, much like biology uses a classification system, to organize information and to help better understand the various dysfunctions or disorders that people experience. So, as I mentioned before, we use a book called the DSM-5. The fifth edition is the current edition of the DSM, the Diagnostic and Statistical Manual of Mental Disorders. In the previous edition, the DSM-4, a multi-axial diagnosis system was used. So you see there are different axes. If you work in the mental health field or the medical field, the legal field, maybe even the educational field, you may come across this multi-axial diagnostic system in case records. So I just want you to be familiar with this. You do not need to commit this to memory. So there are 5 lines or axes of information. Axis 1 is the clinical disorder or the problem to be treated. So for example, schizophrenia or major depressive disorder. Axis 2 is mental retardation and personality disorders. These two categories of disorders go on a separate axis. Axis 3 are medical conditions, any significant medical condition in the previous 12 months. And so sometimes physical disorders can manifest as a psychological symptom or symptoms. After heart attacks, people sometimes experience depression. Sometimes people feel depressed and really sluggish. They go to a mental health professional, and when they're asked to get a medical exam, a physical, they find out that their thyroid is underactive, and that by getting treatment for the thyroid dysfunction, the person ceases to be depressed. So it's really important for mental health professionals to know about medical conditions, current and previous ones. Axis 4, psychosocial factors, things like job loss, loss of a friendship, loss of a parent or relative, any loved one, some big change like a geographical move, etc. Okay, and Axis 5 is a rating scale. So it's called GAF, Global Assessment of Functioning. So people are rated from 0 to 100. 100 meaning excellent function, 0, no one gets a 0, but low numbers suggest that there's significant degrees of dysfunction. The goals of the DSM. First, to describe the hundreds of disorders. Second, to determine how prevalent the disorder is. Okay, third, to guide research. Okay, the DSM also gives mental health professionals a common language for communicating about people who are suffering from a disorder. Now, the DSM does not address causation or etiology. It also does not address treatment. Now I'm starting the psychological disorders. So you see on the slide there are 3 categories of disorders: the anxiety disorders, the obsessive compulsive and related disorders, and the trauma-related disorders. In DSM-4, all the disorders that you see on this slide and the next were considered anxiety disorders. Today we have 3 categories. You don't need to remember these categories, but I want you to know for your edification. And so you see generalized anxiety disorder, panic disorder with and without agoraphobia, specific and social phobias, obsessive compulsive disorder, post-traumatic stress disorder, and acute stress disorder. In the following slides, I'll be going through each of these disorders in some detail. If you look at this chart, on the left you see the DSM-4 diagnoses for anxiety disorders. Okay, on the right, you see what's included as an anxiety disorder in DSM-5. So some of the disorders on the left are no longer considered anxiety disorders, and they've added some disorders like separation anxiety disorder, selective mutism, and agoraphobia as a disorder in and of itself. Again, I won't be testing you on the differences between these disorders. I just want you to have some exposure to the changes in how people are diagnosed today. Panic disorder is characterized by recurrent panic attacks and unexpected, or what we call uncued, panic attacks. People don't know what triggers them. They can happen anywhere at any time. So to define a panic attack, take a look at your slide. It's an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes and during which time a number of symptoms occur. Now, people having panic attacks will also oftentimes report that their panic attack has lasted for a long period of time. When you're in that much distress, oftentimes time slows down and it seems that the panic attack has lasted longer than it actually has. Symptoms of panic attacks include heart palpitations, sweating, trembling or shaking, a sensation of shortness of breath or a sensation of smothering, chest pain or discomfort. Some people end up in the ER thinking they're having a heart attack, and feelings of choking, and the symptoms continue on the next slide. Other symptoms include nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, chills or heat sensations, paresthesias, that means a numbness in your extremities, in your fingers, in your toes, sometimes a sense of derealization, things around you might not feel quite real, a fear of losing control, going crazy, or some people feel that they may be dying. The symptoms are that intense. Now, all of us have probably experienced some of these symptoms when we've experienced intense anxiety. So panic attacks include a cluster of some of these symptoms, and to have panic disorder, they need to be recurrent and unexpected. With panic disorder, with agoraphobia, and with all of the other disorders, in addition to the symptom cluster, the person has to, in addition, experience significant distress and or significant impairment in functioning. So now I'll move on to the next disorder, agoraphobia. In DSM-4 and all the previous DSMs, agoraphobia was diagnosed either with or without panic disorder, or actually the reverse, panic disorder with agoraphobia, panic disorder without agoraphobia. Now it's a standalone diagnosis, and as you see, it's a marked fear or anxiety, about two or more of the following. So using public transportation, being in open spaces, being in enclosed spaces, standing in line or being in a crowd, or being outside of the home. So you need at least two of those. So I'll tell you a story about a woman I worked with some years ago. She suffered from agoraphobia as well as from a number of other anxiety disorders. Okay, she had periodic uncued panic attacks and specific phobia, in which she had cued panic attacks involving elevators and bridges. And in order to avoid having panic attacks, she did a number of things, thinking they would decrease the amount of panic attacks she would have. So she was unable to use public transportation, and she had trouble getting to work because she relied on her boyfriend for transportation, because she needed to cross a couple of bridges in order to get to her workplace, and she had a specific phobia of bridges. Once she got to work, she could not take the elevator because she got extremely anxious and would have panic attacks when thinking about taking the elevator. So she came to see me because she was in trouble with her supervisor for taking so much time running errands throughout the organization. She would need to take the stairs down to the bottom floor, cross at street level into another building, and then take the stairs up to the floor she was delivering something to. And so she was wasting time by not taking elevators. And she also had a fear of being in open places, wide open places. She wouldn't go into a stadium for a concert. Again, in closed spaces like elevators, standing in line caused her a great deal of anxiety. So she would go to the grocery store at 6 or 7 in the morning before there were many people. She did not like being in crowds. And number 5 did not pertain to my client. She would go outside of the home. A common misperception in our culture about agoraphobia is that these are people who will not leave their home. In extreme forms, that may be the case, but many people leave their homes, but they have extreme anxiety as they do so. Separation anxiety disorder was previously categorized as a disorder of childhood. Excuse me, it's now included in the anxiety disorders. It is a disorder of childhood. It's only suffered by children. What it involves is developmentally inappropriate and excessive fear or anxiety when the child needs to separate from those to whom the child is attached. So oftentimes we see this as children go to kindergarten or first grade. Sometimes kids aren't diagnosed. It's called school refusal. And so early in life, in the second year, it's very normal for a child to have some difficulty separating from a parent. When they're left with a babysitter, they may cry for long periods of time. But once a child gets to be around 4 or 5, they should have less difficulty in separating from significant loved ones. So this is excessive anxiety upon separation. Selective mutism was also a disorder of childhood in DSM-4. Now it's categorized as an anxiety disorder. So it involves a consistent failure to speak in specific social situations in which there's an expectation for speaking, despite the individual being able to speak in other situations. And so there's no physical or organic cause. This is anxiety-based. So a child may not speak at all in school, but then when they go home to their neighborhood, they talk with their family and their friends in the neighborhood, or vice versa. So it's called selective. They refuse to speak in certain situations, and it appears that this is functional. The child shuts down to quell their anxiety. Specific phobia. A phobia, as you know, is a significant fear or anxiety. And in specific phobia, we have a marked fear or anxiety about a specific object or situation. People suffering from specific phobia may have cued panic attacks, expected panic attacks, when they know they're going to encounter the object or thing they're very fearful about. Okay, in the clinical profession, if you have a specific fear, you would be diagnosed with specific phobia. But there are many names for phobias. If you Google phobias, you'll find hundreds of different types of phobias and names people have ascribed to those phobias. So you see an example of a few of these on your slide. So you see agoraphobia, a fear of open places, acrophobia, a phobia of heights, claustrophobia, a phobia of closed spaces, hemophobia, a phobia of blood. So lots of different kinds of phobias. Now, on your assignment sheet in Pages, you'll be directed to watch a YouTube video of a woman who has specific phobia. She has a fear of spiders, arachnophobia, and you'll see an example of what it's like for someone living with specific phobia, and she devises her own virtual reality therapy. So you'll get a sense of a behavioral therapy as well when you watch this video. Social anxiety disorder. In DSM-4 and the previous DSMs, it was known as social phobia. So this is significant fear or anxiety about one or more social situations in which the individual is exposed to possible scrutiny, evaluation by others. Now, in social anxiety disorder, as in specific phobia, people can have cued panic attacks. So an example would be someone afraid to give a talk, and when they know they're about to give a talk, they start to have panic symptoms and may have a full-blown panic attack. Years ago, when I was teaching general psychology in the evening, a student of mine asked if she could be exempt from giving a presentation at the end of the class, that she had social anxiety disorder. So she was a woman in her 30s who was going to college since she was 18 years old and still only had about half the credits she needed to graduate, because when she would see on a syllabus that a talk was required, she would drop the course. So social anxiety disorder, social phobia, so anxiety in social situations. It might be going to a party and meeting new people, and people become dysfunctional. They have significant fear and anxiety and possibly panic attacks. GAD, generalized anxiety disorder, is what Sigmund Freud would have called free-floating anxiety. So unlike the phobias where anxiety is attached to a particular object, experience, etc., in generalized anxiety disorder, there's excessive anxiety and worry about a number of things, oftentimes without basis in reality. So you see on your slide that it's marked by excessive anxiety and worry is one of the prominent features. Some people call GAD the disorder of worry. The worry and anxiety needs to occur more days than not for at least 6 months, because we all have periods of stress and worry. Maybe right now is a time for many of you because of the COVID-19 virus. But people with GAD worry about lots of things and lots of activities. And the anxiety and worry are associated with 3 of the following. Okay, number 1, restlessness, or feeling keyed up or on edge. Number 2, being easily fatigued. Other symptoms of GAD, we see number 3, difficulty concentrating and a person's mind going blank. Number 4, irritability. 5, muscle tension. Oftentimes people end up going to their primary care physician because they have neck aches or headaches or back aches, and it turns out they're suffering from GAD. Sleep disturbances can also occur in GAD. So people with GAD, as I said earlier, generally worry about a number of different things, and they don't have a clear basis in reality. I worked with a woman who was afraid her children would choke. especially when they were out in restaurants. Even though she knew the Heimlich maneuver, she had no history of anyone she knew choking, so it wasn't grounded in reality. So an irrational worry about this. She worried that her husband would lose his job. He had a very stable career with a lot of different job opportunities. She worried about money. They were financially secure. And so that just gives you a sample of what GAD can look like. As I said earlier, OCD, or obsessive compulsive disorder, previously was listed or categorized as an anxiety disorder. Now we have a category called obsessive compulsive and related disorders. You don't need to worry about memorizing which disorders go into which category, but just be familiar with each of the disorders. So you see OCD, body dysmorphic disorder, hoarding disorder, trichotillomania, also known as hair pulling disorder, and excoriation disorder, skin picking disorder. OCD, obsessive compulsive disorder. In OCD, we see the presence of obsessions, compulsions, or both. Okay, most people have both, but you can have one or the other. So an obsession is a recurrent and persistent thought, urge, or image that you can't get rid of no matter how hard you try. So we talk about being obsessed about things from time to time. Maybe you had a fight with a friend and you obsess about it, but you don't necessarily have obsessions. So I'll give you an example of people with obsessions and compulsions in a few minutes. Compulsions are repetitive behaviors or ritualistic behaviors performed in response to obsessions, to try to eliminate the obsession. And the obsessions and or compulsions need to be time-consuming. They need to take up at least 1 hour each day, and so they often impair a person's functioning. So unfortunately, I have some videos I show in class, but I don't have them available to switch them online. So I'll talk about some clinical examples. I had a woman with an obsession of going to her kitchen drawer and pulling out a knife and thinking she was going to use it to stab her husband, whom she dearly loved. And so this was very disturbing to her. So this was an image, an obsession that occurred over and over and over again. Okay, I had a student many years ago who was getting in trouble at school because he couldn't make it to his 10 or 11 o'clock class because it took him hours to leave his house. So he compulsively checked things. He was afraid his house would burn down. So he would leave his house and he would need to go back in and check the burners, check any appliances, check his ashtrays to be sure his cigarettes were out completely. He would leave the house, get into his car, and then he would need to go back into the house and do this all over again. And so this took hours before he could actually pull away and come to Thomas More. So this was very dysfunctional behavior and very disturbing to him because people with OCD know that these are irrational obsessions and compulsions. So you see some examples of obsessions and compulsions on this slide. So obsessions, repetitive thoughts, common obsessions are concerns with dirt, germs, or toxins, concern that something terrible will happen, fire, death, illness, an obsession with symmetry, order, or exactness. People will order their cabinets in alphabetically, or they might order their canned goods from tallest to shortest. They might order their cupboards from longest clothes to shortest clothes, and also by color, and they're obsessed with this. In the movie As Good as It Gets, starring Jack Nicholson, you see a really good portrayal of someone who suffers from obsessive compulsive disorder. And when he opens his medicine cabinet in his bathroom, you see soaps lined up symmetrically. Okay, sometimes people who have a compulsion with dirt or germs will, as an obsession with dirt or germs, will then engage in a compulsion of excessive hand washing to the extent that they'll use more than a bar or two of soap a day, and their hands become very red because of the excessive hand washing. Okay, compulsion. So I just talked about excessive hand washing, bathing, toothbrushing, grooming. Although right now with the coronavirus, I guess we all need to be concerned about cleanliness, but we don't need to become compulsive about this. Repeating rituals. Some people come in and out of a door a certain number of times, or they get up and down from a chair a certain number of times. They may need to count to 100 and backwards in order to get rid of an obsession. So as I said before, I had a student who checked doors. Okay, he checked locks, doors, appliances, ashtrays. So people can become compulsive in their attempt to alleviate obsessions. A brain imaging scan of a person suffering from obsessive compulsive disorder shows high metabolic area activity, in the frontal lobe areas that are involved with directing attention. So those are the red areas. So people can't stop attending. They think over and over and over again. Body dysmorphic disorder involves a preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or appear slight to other people. So some people are obsessed about one feature. They think they have a big nose or big ears, and they become preoccupied to such an extent that it impairs their functioning and may cause significant distress. So if in high school you read the play Cyrano de Bergerac, Cyrano had a large nose, and he was enamored with a woman named Roxanne. And Cyrano was a poet, and he had a friend of his read Roxanne poems from the bottom of her balcony, and she fell in love with a friend when in fact she really was in love with the poet, but Cyrano was too concerned about his big nose to reveal the fact for some time that he was in fact the author of these beautiful poems. Now, you see, in the DSM-5, we specify body dysmorphic disorder if it occurs with muscle dysmorphia. So in the last decade, research has found that there are many people, particularly men, who become preoccupied with not having adequate musculature. So these may be people who work out many hours a day in order to build muscle. So they become preoccupied, they become distressed and impaired in their functioning. Because of various media presentations, many people are familiar with hoarding disorder. Hoarding disorder used to be considered obsessive compulsive disorder, but researchers have found that a different brain area is involved in hoarding. It's also more difficult to treat than obsessive compulsive disorder. And so as you see on the slide, hoarding involves a persistent difficulty discarding or parting with possessions regardless of their actual value. So people hoard all kinds of things. We'll see on TV animal hoarders, people who have way too many dogs or cats, and it becomes a health risk to the animal. Hoarding disorder. Trichotillomania, also known as hair pulling disorder, involves the recurrent pulling out of one's hair, okay, resulting in hair loss. And this can be on any part of the body, one part or multiple parts of the body. And repeated attempts to decrease or stop hair pulling doesn't work. People try to stop and they're unable to do so. So you can see where this is in the category of obsessive compulsive and related disorders. Excoriation disorder is also known as skin picking disorder. In this disorder, people have a recurrent skin picking problem that results in skin lesions. They try to decrease or stop skin picking, but they're unable to do so. So now we're moving on to the next category, trauma and stressor-related disorders. In this category, there are 4 disorders: reactive attachment disorder, disinhibited social engagement disorder, post-traumatic stress disorder, and acute stress disorder. Reactive attachment disorder, often called RAD, is a disorder of childhood, and it's now categorized with the trauma and stressor-related disorders. In this disorder, children have a consistent pattern of inhibited, emotionally withdrawn behavior toward their adult caregivers. So these are kids who don't want much affection, who don't respond to tenderness or hugs. They don't want an attachment. They have difficulty with attachment. And oftentimes this is due to neglect or abuse on the part of the caretaker. Not always, but a great deal of the time, RAD results as a result of trauma to the child. This is difficult to treat. I'm not going to talk about it in detail, but just want you to know that it exists as a trauma-related disorder. Disinhibited social engagement disorder is also a disorder experienced by children. Excuse me. It involves a pattern of behavior in which a child actively approaches and interacts with unfamiliar adults. And oftentimes the etiology is some trauma or abuse experienced by the child. These are kids who are disinhibited. They'll go up to anyone. I worked at the Department of Human Services many years ago, and I had a couple occasions in which I brought some young children to the office, and they climbed into everyone's laps. They're hugging people. They're just very disinhibited. If you take them in a store, they'll go up to strangers, and they may want hugs and just exhibit inappropriate social engagement for their age. In post-traumatic stress disorder, a person needs to have experienced a trauma or witnessed someone else who has had a trauma and has symptoms for 4 or more weeks. And so you see some of the symptoms on the slide: haunting memories, nightmares, social withdrawal, jumpy anxiety, and sleep problems. I'm going to talk more about these symptoms on the next slide. The DSM talks about 4 categories of symptoms. The first is intrusion. And so people with PTSD oftentimes experience intrusive thoughts, images, or they have dreams about the trauma. So these are images or thoughts that just pop into someone's mind, and they have a hard time, quelling those disturbing thoughts about the trauma. The second category is avoidance. So people will go to great lengths to avoid being reminded of the trauma. I worked with a woman some years ago who had been severely sexually abused as a child, and she would not go to that part of the city. When she got close to that part of the city, she would get highly anxious. So she began to avoid any contact with anyone who lived in that part of town. Negative alterations in cognitions and mood. So people may be able, oftentimes begin to think about things in negative terms, not just the trauma, but this can generalize to their current situation, and the mood can change. People can become sullen and clinically depressed. Okay, sometimes we see alterations in arousal and reactivity. So some people don't get depressed or anxious, but they get very irritable. They may have angry outbursts when prior to the trauma, they did not have these symptoms. Some people become very hypervigilant. So they're always on alert for any potential danger. So people with PTSD will sometimes go into a restaurant and sit in the far corner of the room diagonal from the door so they can see everything that's going on in the restaurant. So they're hypervigilant to any potential trauma. In some people, we see what is called an exaggerated startle response. I worked with a veteran some years ago who talked to me about being on a date, and he was hand in hand with his girlfriend walking down the street when a car backfired, and he ran for cover behind some bushes and then was very embarrassed after the fact because he hadn't told this young woman that he had PTSD. So an exaggerated response to stimuli that may be similar to the stimuli from the trauma. Now, most people show resilience to PTSD. Only about 10% of women and 20% of men react to traumatic situations and develop PTSD. So we know that Holocaust survivors often show remarkable resilience against traumatic situations. Now, all major religions of the world suggest that surviving a trauma can lead to the growth of an individual. Acute stress disorder. Acute stress disorder shares the same symptoms of PTSD, but someone is diagnosed with acute stress disorder if they experience these symptoms within the first month after a trauma. If the symptoms persist beyond 1 month, then the person is diagnosed as having PTSD. So sometimes people do fine right after a trauma and they develop symptoms down the road. So then they would have PTSD if they have symptoms that cause significant distress and impairment right after the trauma up to 1 month. They're diagnosed with acute stress disorder. So now we move on to a new category of disorders. In DSM-4, they were called the mood disorders. In DSM-5, we have 2 categories, the bipolar and related disorders and the depressive disorders. There are three disorders in the bipolar and related disorders. We have bipolar 1 disorder, previously known as manic depressive disorder, bipolar 2 disorder, and cyclothymic disorder. Bi, as you know, means two, so there are two poles of moods involved. Okay, one is up, the other is down. So people can be manic or hypomanic or depressed. And I'll talk in more detail about each one of these. In the bipolar disorders, there are four possible types of episodes: a manic, a hypomanic, a depressed, or a dysthymic. So in a manic episode, people experience extreme energy. Oftentimes people don't sleep. They may not sleep at all or just sleep for a couple of hours, and they still feel rested even though they haven't slept. You'll be viewing a video of a woman named Mary in a manic episode, and she'll talk about this. Usually people are in an elated and an expansive mood. So some people talk about feeling on top of the world. They're very happy and exuberant, and people can engage in impulsive behaviors that have serious negative consequences, such as spending a lot of money in a short period of time, getting involved in sexual liaisons, even when a person is in a committed relationship. And so manic episodes can sometimes result in psychotic symptoms. You'll see in the video of Mary some of her psychotic symptoms while she's in a manic episode. She's quite delusional. She feels that she's aligned in a special manner with Jesus Christ, etc. Sometimes people in a manic episode become suicidal. Some people, because they're so psychotic in a manic episode, may think they have special powers. There are stories and cases about people who jumped out of high windows to their death, not with the intent of taking their life, but believing that they can fly. Okay, hypo means under. So a hypomanic episode is not as intense as a manic episode. Usually we don't see psychotic features. There's a judgment call for mental health professionals in differentiating a manic from a hypomanic episode. So people may go on spending sprees, they may not sleep as much, they have more energy, they may become more talkative than usual, so less intense than a manic episode. In a depressed episode, we see symptoms of major depressive disorder, so a depressed mood, loss of interest or pleasure in things that used to bring enjoyment. People either overeat or undereat, they sleep too much, don't sleep enough because the depression interferes with their sleep, they may have difficulty concentrating, and other symptoms. Dysthymic episodes involve low-grade depression. So the depression is not as severe as it is in people with full-blown depressive episodes. In bipolar 1 disorder, previously known as manic depressive disorder, people must meet the criteria for a manic episode. The manic episode may be preceded by and may be followed by a hypomanic or a major depressive episode. So Mary in the video is suffering from bipolar 1 disorder. So this slide reiterates some of what I've talked about thus far, so read over it as a mini review. Many great writers, poets, composers, actors have suffered from bipolar disorder. You see on the slide Walt Whitman, Virginia Woolf, Samuel Clemens, Ernest Hemingway. We know that Robin Williams suffered from bipolar disorder, among others. And what some of these people have said is that during their manic episodes, they were extremely creative. Okay, but then they would plummet into a depressed episode and would have no access to their creativity. Bipolar II disorder must meet the criteria for a current or past hypomanic episode and the criteria for a current or past depressive episode. So this is not quite as severe as bipolar I. So alternating hypomanic episodes with episodes of major depression. The medical treatment of bipolar disorder usually involves medication. So lithium is the gold standard for treatment of bipolar disorder. Lithium is a natural salt, which we all have in our bodies, but a dysregulation of lithium seems to occur in people with bipolar disorder. So people who take lithium for bipolar disorder need to get regular blood draws to monitor the level of lithium. Too much lithium can be toxic. So only people who are compliant with treatment can be prescribed lithium. Another possibility is an anticonvulsant medication. So doctors stumbled on the fact that an anticonvulsant and anti-seizure medication stabilizes moods in people with bipolar disorder. So there are different types of anticonvulsants. Depakote is one that's used quite often among other anticonvulsants. Before I move on to cyclothymia, I want to talk about medicine adherence problems. Many people with bipolar disorder have a tendency to go off their medication. Some people go off their medication because they like feeling elated and exuberant. They like feeling high. And so when the medication stabilizes their mood, they feel dull. What we would feel normal might feel dull to someone with bipolar disorder. Some people don't adhere to medication regimens because of the side effects. Others have a difficult time accepting the fact that they need to take a pill in order to control their behavior. So there are many reasons for lack of adherence to a medication protocol. Before moving on to cyclothymia, I'd like to say a bit more about people with bipolar disorder who have difficulty staying on medication. This is a big problem with bipolar disorder. So many people go off their medication because they like feeling elated and high. When they come down to a stable mood, oftentimes it feels dull to people suffering from bipolar disorder. Okay, another reason people go off medicine is because it's difficult for people to accept the fact that they need to take a pill in order to be in control of themselves and their moods and behavior. Sometimes people stop taking medication because of bad side effects. Now, on to cyclothymia. Cyclothymia has to last for at least 2 years in adults, 1 year in children. So this is a chronic problem with periods of hypomania alternating with dysthymic episodes. So these are low-grade mood swings. So people do not meet the criteria when they're depressed for a full-blown major depressive episode, nor do they meet the criteria for a full-blown hypomanic or manic episode. These are chronic low-grade mood swings that cause distress and impairment in functioning. There are 4 different types of depressive disorders: disruptive mood dysregulation disorder, major depressive disorder, persistent depressive disorder, also known as dysthymia, and premenstrual dysphoric disorder. Disruptive mood dysregulation disorder has been recently added to the DSM-5. It involves severe recurrent temper outbursts manifested verbally, for example, verbal rages, and or behaviorally. So, for example, physical aggression toward a person or toward property that are grossly out of proportion in intensity or duration to the situation or provocation. Okay, over the years, there was a high increase in kids being diagnosed with bipolar I disorder. So researchers examined this and they found that bipolar I was not really appropriate a diagnosis for many of these children. So what they found is that there was a lot of mood dysregulation and their behavior was disruptive, but they did not suffer from bipolar. Now, the second criteria you see is mood between temper outbursts is persistently irritable or angry. Major depressive disorder is one of the most common of all psychological disorders. Research has shown that approximately 1 in 4 Americans will suffer an episode of major depression during the course of their lifetime. As you see, in order to have major depressive disorder, you need 5 or more symptoms of a major depressive episode during the same 2-week period. Symptoms must include either a depressed mood or a loss of interest or pleasure. I've worked with many people who look quite depressed. They sound depressed, but when asked if they're depressed, they'll say no. But then if you ask if they have an interest or if they're getting pleasure out of things they used to get pleasure from, the answer will be no. So a depressed mood or loss of interest or pleasure. Depression is sometimes called the common cold of psychological disorders. As you see on the slide, in a year, 5.8% of men and 9.10% of women report depression worldwide, according to the World Health Organization. Given the coronavirus situation, we're apt to see more cases of major depressive disorder, more anxiety disorders, or at least symptoms of depression and symptoms of anxiety. It's also concerning that people who suffer from OCD may find an intensification of their obsessions and or compulsions. So hopefully people reach out for help. For those of you who are experiencing a lot of anxiety or feeling depressed, the campus counselor, as you know through Student Life, is available online, and you can use the link sent out by Student Life to try to connect with Melissa. She's very good, and reach out to her if you feel the need. Okay, medical treatment of major depressive disorder, MDD. So we see some of the antidepressants I talked about in Chapter 2, SSRIs, selective serotonin reuptake inhibitors. They block the reuptake of serotonin at the synapse. These include drugs like Prozac, Celexa, Paxil, Zoloft, among others. Okay, when SSRIs aren't effective in treating depression, doctors then often switch to an SNRI. So this is a serotonin norepinephrine reuptake inhibitor. So this medication blocks the reuptake of serotonin and norepinephrine, two neurotransmitters that are implicated in depression. So when a medication blocks or works on more than one receptor site, oftentimes we see more side effects. So that's why an SSRI is first prescribed for depression. If these two medications don't work, doctors may go back to the older tricyclics. These are quite effective, but they cause nastier side effects that are more long-lasting. SSRIs may cause headaches or stomach problems for the first week or two in people, but if it's tolerable, doctors will ask that you stick with it, and usually those side effects dissipate. And that's not so with the tricyclics. Okay, the MAOIs are the monoamine oxidase inhibitors. You just need to know it by MAOIs, and they too are quite effective. You don't need to remember this, but drugs like Nardil and Parnate are MAOIs. They're effective, but the problem is people have to be extremely cautious about what they eat and drink. So the wrong food or beverage can cause a sharp spike in heart rate and lead to heart attack, stroke, or death. So people need to avoid foods like chocolate, red wine, nuts, cheese, foods that contain a substance called tyramine. And tyramine is what causes a spike in heart rate. Persistent depressive disorder, previously known as dysthymia. This is chronic low-grade depression for at least 2 years in adults and 1 year in children. Sometimes people with persistent depressive disorder don't recognize that they have depression because they've experienced this low-grade depression for so many years that it feels normal to them. I've had many people in my clinical practice over the years come to me for treatment because a relative or friend will say, all you do is whine and complain. You just don't seem like a happy person. And people are often surprised by this. They don't identify as depressed individuals. Premenstrual dysphoric disorder. This is a new diagnostic category in the DSM-5. This is not PMS. Premenstrual dysphoric disorder involves severe depression, severe mood swings, anxiety, or irritability occurring right before the onset of one's menstrual period. Then the person sees improvement of symptoms within a few days of menstruation and minimal or no symptoms following menstruation. So this is a severe case of depression, anxiety, and mood swings that can result in dysfunction and significant distress. Okay, etiology or cause of depressive disorders. Okay, biological contributions include neurotransmitter dysfunction. So as I've talked about previously, serotonin, norepinephrine, and dopamine can be dysregulated and dysfunctional. Heredity. Mood disorders tend to run in families. The rate of depression is higher in identical twins, about 50%, than in fraternal twins, about 20%. And we also know that the overproduction of stress-related hormones can lead to depression. Functional and anatomical brain changes with depression can occur. So various changes including reduced neuroplasticity, including reduced neurogenesis, the creation of new neurons in the hippocampus and in synapses within the cortex. Okay, psychological contributors to depressive disorders. A lack of reinforcement can lead to depression. If we're not getting positive feedback from people, we can become depressed. Okay, so we need to keep this in mind during this time of COVID-19, that we need to be in touch with family and friends, even if it's through telephone calls, text, and other sources of social media. So reinforcement is important to stay healthy. Sometimes people get depressed because they lack good social skills, so they don't have many friends or contacts, and so they're not getting the reinforcement they need to stay healthy. Some people who are depressed engage in patterns of dysfunctional thinking, and I'll talk more about this on the next slide. Okay, learned helplessness, which I talked about earlier in this semester, can lead to depression. So you know the experiment about Martin Seligman and the dogs. He put dogs in cages, closed the door, and locked the door, and then delivered mild electric shocks, and the dogs would scramble to escape the shock. And this happened over and over again, and eventually the dogs would just sit down on the floor of the cage and cease to try to escape. They learned to be helpless. So even when Seligman opened the door, the dogs would just sit and do nothing to help themselves. So learning to be helpless can lead to depression. A lot of research shows that patterns of negative thinking can lead to negative mood states. So you see on the chart on this slide, the breakup with a romantic partner. On the left, you see someone who has a negative explanatory style after the breakup. And so in a negative explanatory style, a person sees the situation as stable, global, and internal. So in terms of being stable, the person might be thinking to themselves, I'm never going to get over this. Okay, second, they think in global terms. So they might be saying to themselves, without my partner, I can't seem to do anything right. So this encompasses my entire world. Internal, our breakup was all my fault, when usually breakups are in some ways a two-way street. So if you think about things in this negative way, you're apt to become depressed. People who are healthier tend to think about difficult situations as temporary, specific, and external. So in terms of temporary, this is hard to get through, but I know I'll eventually get through this. Okay, specific, I miss my dating partner, but thankfully I have friends and family, and I'll be okay. External, it takes two to make a relationship work, and it wasn't meant to be. So temporary, specific, and external ways of thinking lead to successful coping. Okay, the cycle of depression. So usually depression begins with stressful events. Okay, if we think about these events in a negative way, if we explain them in a negative way, like I mentioned on the previous slide, we're apt to find ourselves in a depressed mood. Okay, when we're in a depressed mood, we then oftentimes experience cognitive and behavioral changes. So we continue to think in negative ways, spiraling deeper into our depression, and our actions may change. We may pull back from people, and this can fuel personal rejection, or some people when they're depressed can be angry and aggressive, and this too fuels personal rejection. So that then leads to more stress and the cycle continues. The most severe form of behavioral response to depression is suicide. So each year, over 1 million people commit suicide worldwide. And so there are various statistics on suicide. There are differences between nations, there are racial differences, gender differences. More women attempt suicide, but more men complete suicide due to the kinds of methods they use. Men tend to use more lethal methods. Age differences, young people, teenagers, young adults, and the elderly are more at risk than other age groups. And we're going to look now at indicators of possible suicidality. Indicators of possible suicidality. First, we'll look at talk. If a person talks about killing themselves, this needs to be taken seriously. If they talk about feeling hopeless, having no reason to live, being a burden to others, feeling trapped, or being in unbearable pain, they may be at risk. Behavioral indicators of possible suicidality. So the following behaviors may signal risk, especially if they're related to a painful event or a recent loss. Okay, an increase in the use of drugs or alcohol, searching for ways to end their lives, going online, searching for methods, withdrawing from activities, withdrawing from family and friends, finding or giving away prized possessions, and aggressive behaviors or extreme fatigue. There are mood indicators of possible suicidality. So depression, anxiety, loss of interest, irritability, agitation, anger, humiliation, and shame. And what's really important to keep in mind, if someone suddenly, after a period of depression or anxiety, feels relief and sudden improvement, many people think this is always a positive indicator. But oftentimes people carry out their suicidal plan when they begin to feel better and they have enough energy, and when they make the definite decision, there may be relief. So for both reasons, having made the decision and being at peace with it and having the energy to carry it through can be a huge risk factor. Okay. Health conditions and mental health conditions that are possible indicators of suicidality. Obviously, depression, substance use problems. One of the big risk factors is that people are disinhibited when they're under the influence of alcohol or some other substance. And so judgment is blurred and there's a disinhibition, and so that puts people at higher risk. Bipolar disorder. People in manic episodes, as I mentioned, may unintentionally kill themselves. So this would not be considered suicidality, but it isn't always clear to people. They may think they can fly and jump off of a tall building, but sometimes the mood swings become so severe that they can't tolerate either the depression or the mania or both. Schizophrenia, anxiety disorders, traumatic brain injury, and any serious health condition that includes pain can put a person at risk for taking their life. Environmental risk factors of suicide. So if a person has access to lethal means, that puts them at very high risk of suicide if they have the intention and the plan. And so mental health professionals and physicians do what is called a lethality assessment. So if a person is talking about suicide, they ask about whether or not they have a plan, and then they ask if they have the means to carry out that plan. Okay, another environmental risk factor is prolonged stress. So any kind of intense stress that goes on, and this includes bullying and harassment. Okay, very stressful life events, transitions, or losses, and exposure to another person's suicide. Sometimes this unconsciously gives the person permission to take their own life if they've been feeling suicidal. We call this the copycat effect. If you find yourself having thoughts about suicide, promise yourself not to do anything right away. Usually these feelings pass with time. Avoid alcohol and drugs. Make your environment safe. Get rid of guns, lethal weapons, get rid of drugs and alcohol until you feel safe and no longer suicidal, or go to a safe environment. Remember, there's always hope. Situations usually improve with time. And finally, and maybe most importantly, is don't keep suicidal feelings to yourself. Talk to someone. Talk to a friend, talk to a family member, go to a professional, but don't keep the feelings to yourself. If someone comes to you and says they're thinking about taking their life, start a conversation. You might say, well, tell me more about that. So you want your friend or family member to share their thoughts and feelings. Some people have the misconception that if you talk to someone about suicidal ideas, it will make the situation worse. And in fact, if anything, it can be quite helpful. So you want to engage the person in a conversation. And as you listen, you want to stay calm, you want to be empathic, and don't judge. Okay, and then try to get your friend to seek help. If they won't seek help with you, you go and tell someone who can take some action. On to the next category of disorders, dissociative disorders. There are 3 disorders in this category: dissociative amnesia, dissociative fugue, and dissociative identity disorder. Dissociation. Dissociation in and of itself is not necessarily pathological. You see the definition, it's a separation of a part of the person's consciousness, memory, or identity. And so people in everyday life who are functioning well may have dissociative episodes. So, for example, if you drive to school every day and take the same route, you drive to work every day and take the same route, your consciousness may be split or separated. You're paying enough attention that you can get to work safely, but you couldn't report everything you've seen on the way because your head is somewhere else. Your consciousness is involved, let's say, in what you intend to do with the rest of the day. So dissociation can be a normal event. A study was done outside of a prison where a serial killer was about to be executed, and there were several stays of execution. And some college students took questionnaires to the various media folks who were outside waiting over 72 hours, many without sleep. And they gave them a dissociative questionnaire. And the majority of these news people were experiencing symptoms of dissociation because they were very stressed and they were sleep deprived. So this would not be pathological. Dissociative amnesia. Amnesia, as you know, means a loss of memory. And so in this disorder, there's a sudden, partial, or total loss of important personal information or recall of events due to psychological factors. So this is a psychological problem. Sometimes people have brain injuries and they have amnesia. This is a psychological forgetting or amnesia. Someone may be traumatized and then they dissociate. Dissociative fugue. Fugue coming from the Latin meaning running. If you think of a fugitive, fugitive is someone running from the law. So some people call this the running disorder. So in dissociative fugue, the person adopts a new identity. They have a complete loss of memory of their personal circumstances and self-identity. And they unexpectedly travel to a new location. And so sometimes we see this in the news. Someone will go to a different geographical location, a loved one will report them missing, and a picture of them will show up on the nightly news saying, if anyone has seen this person, please contact the authorities. And so it's quite an interesting disorder. I used to have a video of a man who was found by the police on the side of the road. And when the police officer asked him what was going on, he said he ran out of gas. He didn't have his wallet. He didn't know who he was or where he was from. And so the police officer escorted him to a local emergency room. And again, he could not tell the psychiatrist who he was, where he was from, but he had all his other cognitive functions intact. He could add, subtract, etc. He knew who the president was, what year it was, but he lost his self-identity. Now we move on to the schizophrenia spectrum disorders. In DSM-4, we talked about schizophrenia and the related disorders. Now, the conceptualization is that schizophrenia and other disorders lie along a spectrum of severity. Sometimes schizophrenia is called the cancer of psychological disorders, whereas depression is sometimes called the common cold of psychological disorders. And so schizophrenia is a chronic disorder, and as you see on your slide, it's characterized by severely impaired cognitive processes, personality disintegration, mood disturbance, and social withdrawal. There are two types of symptoms in schizophrenia, positive symptoms and negative symptoms. Positive in this sense does not mean good. Negative doesn't mean bad. They're just two different types of symptoms. So the positive symptoms include hallucinations, delusions, and disorganized thinking and behavior. So hallucinations are perceptual disorders. They can happen in any of our five senses. So visual hallucinations, auditory hallucinations, those are the two most common, auditory being the most common. Delusions are false beliefs that have no basis in reality. And some people get quite disorganized in their thinking, and so their speech is disorganized as well as their behavior. Now, the negative symptoms are the absence of appropriate behaviors. Okay, so expressionless faces, rigid bodies, so flat affect, among others. So just know generally what the positive and negative symptoms are. There's more in your textbook about these. There are three phases of schizophrenia. Okay, the first is prodromal, followed by the active, and then the residual. So most people who suffer from schizophrenia are diagnosed when they are in the active phase of schizophrenia. During the active phase, we see positive symptoms. So people hallucinate, or they have delusions, or they become very disorganized. And that's when family and friends recognize there's something really serious going on. The prodromal phase, the first phase, is the phase that leads up to the active phase. In this phase, we usually see just negative symptoms. So people may have flat affect, they don't express any emotion, they may withdraw from social interactions, they may be somewhat different from the norm. They appear a bit odd or unusual in their thinking or their behavior, but they don't have, full-blown hallucinations or delusions in this prodromal phase. Sometimes their hygiene becomes lacking, and then when they get into the active phase, oftentimes in late teenage through the 20s, we begin to see more unusual behaviors. We see the positive symptoms. The residual phase follows the active phase. And in the residual phase, we have sometimes positive symptoms that decrease in intensity and frequency. Some people in the residual phase only have negative symptoms, so they cease to have hallucinations and delusions. So schizophrenia is a chronic disease. Some people can manage it. There are different degrees of severity. Schizophrenia looks different in different people. It's a very complicated syndrome with a lot of different manifestations. Usually, schizophrenia is treated by way of antipsychotic medications. Here you see on this slide DSM-4 categories of schizophrenia. I just want to mention these. You don't need to commit these to memory. DSM-5 ceased to use these types because many people don't fit into any one category. So paranoid schizophrenia, disorganized schizophrenia, catatonic schizophrenia, and then most people fell into the undifferentiated category because they had a mixture of symptoms. Now, when I started the slides on schizophrenia, I talked about the schizophrenia spectrum disorders. So you don't need to know about the disorders other than schizophrenia, but I wanted you to be aware of the fact that schizophrenia is now categorized along a spectrum. So there are disorders like brief psychotic disorder, schizophreniform disorder, schizoaffective disorder. And for the purposes of general psychology, you don't need to commit those to memory, but I'm just bringing it to your awareness. Personality disorders are characterized by inflexible and enduring behavioral patterns that impair social functioning. Usually people with a personality disorder have difficulty in their interpersonal relationships. Some are without anxiety, depression, or delusions. So these are not people who have full-blown psychoses. They just have a great deal of difficulty in getting along in social interactions in various ways. So there are three clusters of personality disorders. The DSM-5 no longer uses these clusters, but I think it's a good way to think about them and to remember them. So the first cluster is called anxious and or fearful, and these disorders are in that cluster: avoidant personality disorder, dependent, and obsessive compulsive personality disorder. So the avoidant person wants relationships, but they avoid them because they're very fearful of rejection. Oftentimes they don't feel very socially competent and they pull back from relationships, but they're usually quite lonely people and in a lot of distress. The dependent personality disorder is someone who has pervasive problems in making decisions on their own. They're always looking towards someone else for advice or their opinion. They really have a hard time with autonomy and independence. Obsessive compulsive personality disorder is different from OCD, obsessive compulsive disorder. Obsessive compulsive personality disorder is a style of being, a personality style. So these are people who are quite rigid and flexible. They don't have obsessions and compulsions, but they're very perfectionistic and sometimes almost ritualistic in their behaviors. These can be people who are hard to live with because they see their way as the only way, it's the right way, and they're quite inflexible. The next cluster is the odd and eccentric, and this includes schizoid, schizotypal, and paranoid. So schizoid and schizotypal sound like schizophrenia, but these people are not full-blown psychotic. So the schizoid person doesn't demonstrate much show of emotion. They usually have flat affect. They have a preference for being solitary. They usually don't have many friends or family. They like solitary activities. If they get a job where they need to interact with other people pretty regularly, they can have some difficulty. And so schizoid. Schizotypal, if we put these on schizophrenia spectrum, schizotypal would look more odd and unusual than someone suffering from schizoid personality disorder. So their appearance may be atypical of the norm. They may look a bit odd, their hygiene may be lacking. They may talk in some odd or unusual ways, use words in ways most people don't use them. And so they're a bit more disturbed, if you will, than someone suffering from schizoid personality disorder. But again, they don't have full-blown hallucinations, delusions, or full-blown disorganized behavior and speech. Paranoid. So paranoid is what it says. They have a paranoid style of being in the world. They don't have paranoid delusions, but they're distrustful of others pretty pervasively. They don't let other people get close. They're concerned that if they share information, that information might be used against them. So there's a paranoid flavor about a person suffering from paranoid personality disorder. So on to erratic and emotional. These are ones you may be familiar with. These are oftentimes portrayed in novels, on TV shows, movies, etc. So we have history on it. This is someone who's highly emotional. And the emotions don't run deep. They display emotion for the purpose of gaining attention. Oftentimes they dress in very flamboyant ways, again to be the center of attention. So these are people who want to be at the very center of attention. Narcissistic, we all know about narcissistic qualities. People can have narcissistic traits but not suffer from narcissistic personality disorder. You need a full cluster, at least 5 symptoms to be diagnosed. So a narcissist is very much preoccupied with oneself. They suffer from grandiosity. They think they're more special than other people. Oftentimes, they see other people as extensions of themselves. They don't have a lot of empathy. And then the borderline personality disorder. These are people who have a very shaky sense of self. And so oftentimes you'll find in romantic relationships a pairing between borderline and narcissistic. The narcissist likes to be admired. The borderline doesn't have strong enough sense of self, and so they'll look to someone who seems to have that full sense of self. And so oftentimes they pair with the narcissist and they admire the narcissist. But oftentimes this is short-lived because everyone disappoints the other person from time to time, and the borderline, when they are disappointed, oftentimes end a relationship very prematurely. So borderline personality disordered folks oftentimes have very short-lived relationships. They have a shifting in mood states. Sometimes people with borderline personality also have bipolar 1 or bipolar 2. They're impulsive, among other traits. Emptiness is a big one. They have a sense of being empty most of the time. Antisocial. So we talk about antisocial personality disorder. These are people who think they're above the law. They have a tendency to violate the law. They don't have any remorse when they hurt other people. Not all people with antisocial personality disorder have been in trouble with the law, but there needs to be a history of antisocial behaviors prior to age 15 in order to be diagnosed with antisocial personality disorder. And so read more in your book to get a little more clarity on some of these personality disorders.